things we looked at. And we knew we wanted to improve. There was evidence from bundled therapy that people like Jim Duddle, who some of you may have come across from Kaiser, and others have been doing, that demonstrated even within a relatively short time period of 1 to 2, 3 years, you could get these substantial drops in major cardiac or adverse cardiac events like heart attacks and strokes. And what you're seeing here are different lines that as you add on additional meds, you start out with an ACE, you can add in thiazide and some others, you get down to these 50 to 75% drops, which was seems unlikely, and yet the evidence is starting to bear it out. And so with that, so we had basically, by 2010, there was agreement from a group like you that said, okay, yeah, we got to improve quality, sure, and heart attack, strokes, bad, we'll go for that. And Tony was brilliant. He came up with this, not just a goal of reducing it. He said, we're going to make San Diego a heart attack and stroke-free zone. This was throwing the hat over the wall. This was something bigger and unreasonable, a little bit bemusing, but kind of cool. And so what I want you guys to understand is, I'm going to highlight some things of where things are at now. It didn't start out that way. It started with meetings exactly like this. And you had people who were committed. We didn't exactly know what the hell we were doing, but we had some general goals. We had this sort of basic vision of sort of how things would fit together. There was the University of Best Practices, which you're part of now. There was, after many discussions with some of the provider systems, a decision that we'd have a separate data group that initially would really just serve as what we were describing as a safe venue, a place where the healthcare systems could start to share data, get to know each other, hopefully maybe share a little bit of their best practices or what's working for them and not. But with both of these, from the beginning, with that heart attack, we're going to be in a heart attack stroke-free zone, and this, from the beginning of our discussions, it was, okay, we're going to do a quality collaborative. You can do that, where we track how different systems are doing, and we work on improving, and we share best practices. But there's going to be this other piece, which is you're also going to need to combine your data. We're going to combine your numerators and denominators, and we want to see what impact you're having on the population, and we want to eventually be coming up with approaches that go well beyond the walls of the office. And again, we didn't know what that looked like exactly. Some of us had different views, but as I mentioned, one of the keys was to get sort of a campaign that helped kind of crystallize what it was we were all up to. And this was the Be There campaign. It was a well thought out campaign that we never actually necessarily executed initially, but it articulated and put it in pictures, and it really essentially was tugging at the heartstrings, and would go from either being very gentle to you want to be there to heart-wrenching, guilt-rendering, you should have been there, kind of, but it was, and there was this notion that it wouldn't just be the patient, it would be that other people around them would be sort of there to help support them. This was enough to sort of start communicating with others around us and in the community of, hey, this is what we're up to, this is what we're trying to do. And that started to attract interest in funding.
I just want to interrupt you for just a moment to acknowledge that Liz Helms
Oh, yeah.
and the California Chronic Care Coalition led the development of the Be There campaign, which was a huge amount of work, many, many late nights across the right care stakeholder groups. It never did go up on the air, but it was motivational across all of the groups.
It was a catalyst. It was one of these small but crucial tipping points. And one of the, you know, to further acknowledge Liz, and, you know, it was something where it was resonating, and she was in communication with lots of chronic care coalitions or other entities, not only in California but around. But it was something that others wanted to immediately sort of say, oh, that's really great. Can we take it on, and so forth. But yeah, Liz, Hattie, Warren, there are others here, Carla. I mean, this was a huge effort from a lot of core people, and niceties aside, it takes a village, and that goes without saying. All right, so one of the things, so this is sort of kind of looking at the general themes and stuff. So this has some similarities to the three right care initiative triangle things, but it's basically we're looking at community activation, healthcare activation, and healthcare system activation. Okay, so my role on this thing is I'm the data, I've served as a co-chair of the data group with Jim Duddle, so I'm gonna disproportionately focus on that. I'm gonna highlight some of the other things it's doing and try to get through some of this and get to some discussion. Any questions at this point? Okay. All right, so initially, there were 8 groups that decided to join in. There were a few other systems like the Navy and the VA that did, and some smaller groups. But collectively, these represented a big chunk of the the care in San Diego. And so the other thing to notice is that this is kind of a diverse group. Some of them are competitors, but some of them, for example, like the community clinics, are very, very different than, say, Sharp-Reed-Steele, which mostly dealt with commercial patients and so forth. So there was a lot of uncertainty as to how that would play out. I'm going to kind of go through this very quickly. I'm not going to bore you with the details, but basically the main points are, it did start out, I mean, we had some initial funding, but by the time we got this started, that sort of dried up. So for a while, it was really, it was a labor of love. It was in-kind resources, and one of the not entirely unexpected things but surprising things was a lot of the medical directors kept meeting because they got value out of it. They got value out of it because they were, initially with some kind of facilitator who was neutral, they were getting to share not only data, but share some of their challenges, some of their successes. But they also got to, they had some contact with people, but really as competitors, and there was sort of this growing mutual respect and sort of a camaraderie. And so, it was basically, there was a little bit of sitting around the table sharing food. Eventually this stuff, we kind of, let's see what I'm going to highlight here. I think there was, besides, and I'm going to show you some of the results of the data, but I wanted to just highlight that this was something much more than over time than just sort of sharing some of the data that they had within their system. You know, at an aggregate level, as we were talking about in the data group meeting right before this, the fact of the matter is many of these systems have, or during the time we were working together, had access to really sophisticated, way more you know, efficient and detailed analytic software, or population health software than we could ever manage to do. And you know, they shared some of the results of that, but that wasn't, again, what proved to be sort of the value here. I think the value was really around sort of sharing the stuff and starting to look at a population level. I wanted to...
Could I interrupt you?
Yeah, please.
Could you tell us a little bit more about the money that initially came in? And specifically, how long were you funded for? And what was the data used primarily for the aggregate data analysis, or was anyone supported in their data gathering process?
Yeah, so the overall GO grant was like a $4 million grant. It, the prime on that was UCLA, and we had to. I mean, there were lots of traditional kinds of studies, and we had some pilot studies out of San Diego, one on or a couple on medication therapy management. We had those. There was. I think in terms of the total funds for, you know, by the time we got to the point they wanted to serve as a data, you know, sort of the neutral data people, I think we had about $30,000 left. So that was enough money for us to set up, or maybe $35,000. We thought we might get some more. But we set up the agreements, and we set up some, you know, basic data templates, and that's all it really took. The rest was, I mean, you can have a research assistant or someone who knows how to use Excel do most of the basic graphs. It's not, at least initially. So the one point I wanted to make is this wasn't all hard work and camping. You guys have a pretty cool venue, but we have a really cool venue. But all right, so here's just really quickly. So you know, we again initially there was this tremendous hesitation to share data. You know, like even though what we were initially asking for was data they already shared publicly, it was and as I was showing the folks in the data group, you know, in terms of the data agreements that were, you know, these marked, we're ready to go, they were generic non-disclosure agreements, and other than the mutual non-disclosure agreement, they were basically ones that they were permitted to share the data for, you know, in general, but it served a purpose, and it was important to have everybody comfortable and so forth, and they really did sort of have some teeth to it. But the point is, what we asked for was fairly basic, and what we got was immediately getting to see some of the, you know, the knowledge, the tools, the approaches, the challenges at a way more fine level of detail than, you know, in the safety of this group, and that was really crucial. I'm going to just kind of skip ahead. These are, you know, sharing some of the challenges.
I know you're in a hurry, Alan, but that slide that you just showed on the change in the percent of patients receiving the dual therapy is just such an important slide.
Okay.
Can you just spend a little bit of time talking about that?
So this is actually, I believe, from one of the, or a set of the community clinics that were part of our group. And they had been participating in initiatives, some of it funded publicly. And over a relatively short period of time, they were able to dramatically raise the rates at which their patients with cardiovascular risk were on statins or on bundled therapies and so forth. And one of the things we're looking at, if some of you have heard about this, there's these mysterious inflection points of where the population rate of, say, AMI hospitalizations dropped by several percentage points around the time some of this was going on. What we're finding when we do the back of the envelope calculations is some of these systems and collectively, when you've got different groups working on it, it doesn't take much to move your AMI event rate or hospitalization rate down that much for a population, especially if you're targeting at-risk populations. And so these things we're getting to see some of the underlying data that may explain some of the improvements. Okay.
Thank you, that was super helpful.
All right, here was, this was the, all right, I'll confess, this was the least fun part of it. This is when the medical directors were getting into root cause analysis, and it was all this deliberative process, and eventually, thank God, they decided to just go for focusing on or essentially using the Measure Up, Pressure Down campaign that AMJA had developed, and Jerry Penso, who had worked, helped set this up. But it was that kind of detail, and I mean, just the level of conversation was really pretty striking to see it across different systems, and it did lay the foundations for them being very serious about collectively doing this. And here's, Measure Up, Pressure Down as an example of one of the kinds of initiatives that, it wasn't just sharing data, it was starting to find ways that each system could focus on improving their own care, but also what might start to have some impact at a population level. And so, here was what I thought was a well thought out campaign, because they really had these different planks, and they were based on best practices and lessons learned from systems around the country. And sometimes it came down to just teaching people how to measure the blood pressure and teach them, again and again, and that made a huge difference. And you can go through any of these steps, but as systems started to go through it, it really made a big difference. Okay, so these are some fun slides. So we started, about 2012 is when we got the data agreements in place. And remember, we're collecting numerators and denominators on measures like, is your LDL cholesterol controlled if you're diabetic, blood pressure controlled if you're a diabetic or a hypertensive patient. And it was actually right around 2012 when a lot of the systems started to really struggle and really try to capture blood pressure well. But so one of the things, without paying too much attention to the size, one of the things that surprised us, even though we only had partial data from a lot of the systems, some of them aren't capturing their PPO or IPA patients very well. A few thousand here, a few thousand there, it starts to add up. And by 2014, we found we had almost 200,000 covered people with hypertension, and I think it was about 80 or 90,000 with diabetes. And that the exact numbers are kind of unknown, but from some of the surveys, it estimated that to be about 25% of the population. And here, just to give you a little better sense of the distribution, this is changing at times. Sometimes, again, some of the systems that are shown there, they add on a whole other business line that they're tracking or something, or we're having other groups starting to join now that this is kind of this established group. It wasn't always pretty for those of you in the data group or whatever. It was, this is just showing, we went back and just really wanted to kind of figure out when did we have reasonably consistent data from the different groups. And so we threw out some measures, but really by 2012, we started to get it, and by 2013, it really, by the end of that year, it was really good. So here's just starting to show, and this is pretty basic, but it's compelling to a group or as providers and others. But what you can see is, remember we've got in 2014 you've got a different mix, and then you're adding in more groups of different quality. So it's not that the care got worse; it's just that our population got more diverse in seven. So here it dropped down to 72, and then starts creeping back up to 74. So,
Alan, was your hand at the bottom, the number of groups that were in the?
yeah, it was.
So 2, 2, 4, so you're adding groups?
Yeah, and to be clear and for full disclosure, so one of the 8 is the Council of Community Clinics, which was probably about 7 or 8 community clinics or more under it, and now we're in going forward, we'll probably be having the separate clinics. So again, Sacramento is a smaller population, but it really doesn't matter. The idea is within your population, if you have most of the leading providers, you can make an impact. And this is just one of the things we're doing some back of the envelope calculations, and so here's where we were on our whole population, and with each percentage point, it was about 1,800 more patients, and so we reached 74% by 2014, and we did some extrapolating out as just to kind of see what we might do, what sort of impact we might have, just if we were doing what we were doing, and we tracked it out and realized that a 2% increase in the performance for the groups, if and some had farther to go than others, but if we did the average up, it'd be about a 2% overall rate, or it would be about 10,000 San Diegans who were having, now blood pressure controlled who wouldn't have been before. And again, though these are big numbers, it's still probably, we have a long way to go in terms of getting everybody. So we recently, one of the things the Be There leadership asked us to do is to do just a brief assessment and kind of look back. And I don't know how clear this is, but while just sort of proving the feasibility and desirability of, or one, it was feasible for diverse groups to do this, and the data was not necessarily perfectly comparable, but pretty darn close. It's what really though were the sort of surprising takeaways when you look at not only what the group accomplished, but what developed because of the group's presence and the group kind of over time becoming more and more sophisticated and a consistent thing there, in combination with the University of Best Practices, it really was the foundation for things taking off in San Diego. To have a group of providers or delivery systems working together, even though they might be competitors or from different groups, it's kind of unusual. And then to have sort of this, the added thing where you've got a wider group of stakeholders working with them, that has made possible some interesting things. What we found was really the kind of the distinguishing characteristic of this, was that it wasn't simply a quality improvement collaborative. We did that, and it's a good one, probably more rigorous than some. But from the outset, it was also, we were going to look at their performance across combined. What's your impact on the population? How do we as leaders of, community leaders, how do we work among ourselves or between ourselves and other stakeholders, including patients and public health and whatever, to, improve health outcomes and, where we're running into barriers, what can we do? And that made a huge difference. And one of the points I got is also, there's this question, you were asking about the funding and so forth, which is how much funding do you have and so forth. And again, for a lot of this, now we've got 4 or 5 different kinds of projects that are, some of them are really groundbreaking, are already getting some national attention. It's like $10 million across different grants. But the reason why people like me or the medical directors or people like Liz, others have been willing to devote time to something like this, it's chicken soup for the soul. It's probably helped me be here too, besides the fancy therapy. It is antidote to cynicism and to the frustration of inertia. It's a chance for you guys, or it was a chance for us to sort of do something very unreasonable in a competitive and time-constrained and resource-constrained world. As it turns out, while there is some maybe no nobility to it or whatever, it's turning out to be a really good deal for the participants, because the different systems, really the only ask of them was that they share aggregated data and come to these meetings. And what's happening is with the funding and stuff and the different projects, they're getting, it's adult education for physicians and medical directors on how you move to the next level, how you address social determinants. It's working with across systems and so forth. Anyways, let me kind of go through some stuff really quickly. Sorry. So this was kind of the conclusion. Yeah, it was feasible to get the data, and it could have an impact. And it was kind of unclear how the improvements in care are playing out across different populations, subgroups, and geographic areas within SD. So remember, we started with this very basic data. Okay, so this is a sign of I dropped off a kid to college because the slides are out of order. But basically, this was what was going on at about by 2015, 2016. It had branched out, and the University of Best Practices, which you guys are, there was lots of spin-offs efforts where we were doing some stuff in some of the harder to treat, more diverse populations and so forth. And I'll tell you about that in a second. Lots of different partners involved. One of the ones which is, I said that there's some efforts that are probably going to get national attention. So one in San Diego, there's an area called Southeast San Diego, which is a high proportion of African Americans and other minorities, very, very poor health stats, and kind of the place where everybody goes to try to help fix them. And there's a lot of distrust and there's of helpful outside organizations. We were able to get some grant from grant funds with the help of one of the IPA physicians who did a lot of work with these with African Americans and others. And anyways, long story short, there are now 30 African American churches of different denominations who are meeting regularly around the issue of addressing, reducing heart attacks and strokes And they are taking some of this, the Be There literature and some of the other materials